Can you unmute yourself just for 1 second? Okay, perfect. Okay. All right, welcome everyone. Thank you for joining. This is our now 4th LympheHeroes Houston virtual meeting. I'm one of the co-founders. My name is Cam Ayala. I am a primary lymphedema patient and a national ambassador and advocate with Learn. And I'm also a local compression therapy consultant with LymphePress. That's one of the pneumatic compression pumps. And my partner Sophie, who I'll introduce here in a few moments, but really our whole reason for creating LympheHeroes almost a year ago, it'll be a year in October, was really just to, again, cultivate this community of lymphedema therapists, physicians, and eventually phase 2, we'll get some patient advocates involved, but really an opportunity for us to all connect and to collaborate and to kind of have a safe space where we can talk all things lymphedema, a variety of topics, a variety of different sponsors and speakers to, again, really make this lymphedema community stronger. So the goal is hopefully here in the next couple of months, maybe for our next meeting, we'll try to get a venue so we can perhaps do this in person, because we do know there is an inherent value in that face-to-face interaction. So once we can find a venue, we'll also send out a survey at the end of this presentation to see if you guys have any topics that you want us to cover at the next meeting, any potential speakers, sponsors, and then again, if you're interested in perhaps doing a in-person meeting. So I'm going to turn it over to Sophie real quick for her quick introduction, and then we'll introduce our speakers.
Hi, everybody. My name is Sophie Long. I am the certified clinical compression specialist with Women's Health Boutique and Second Silhouette here in the Houston area. I'm also the other co-founder for LympheHeroes. We can't thank you guys enough for joining us on these quarterly meetings. And a little bit about Women's Health Boutique and Second Silhouette, and then we'll let the speakers get started, is we are a medical provider for the South Texas region. We have 3 Houston area locations. Our business is broken up into 2 parts. We service the breast cancer diagnosis patients anywhere from pre-surgery to immediately post-surgery, and then thereafter. We've got products and things like that that insurance allows patients to get, as far as prosthesis and bras and leisure forms and things like that. But the other side of the business, which is my favorite side, is the compression aspect of it. So we work with patients who want to utilize their insurance provider to obtain either compression garments that they can use in the acute phase, and then compression garments that they ideally will use for maintenance and lifetime. There's myself and another senior fitter on staff that covers all of the Houston area, and we cover really South Texas. But we carry all the major compression brands. We do everything from over-the-counter to custom to Velcro, foam chip nighttime garments, and all the above. So that's pretty much what I do. I see patients mainly, and I work with therapists mainly in the clinical setting, but I do also see some of those trickier stage 2 and stage 3 lymphedema patients in the store that need a little bit of brainstorming and troubleshooting. But that's pretty much what I do. Again, there is a chat box at the bottom. So if there's any questions that come up during either presentations, feel free to shoot your question there, and we will get to the Q&A at the end. And we can't thank you guys enough for joining. Like Cam said, we're less than a year into this. This actual meeting had our biggest turnout of registration. So thank you guys so much for that. And we look forward to hopefully hosting the next one in person and being able to see everyone in real time. So I will pass it back to Cam, and he will introduce our first speaker.
Awesome, thanks, Sophie. So I have the esteemed privilege of introducing this next speaker. I'm always excited to do these introductions, but extra excited for this particular individual. For those of you who kind of know my story, I was diagnosed with primary lymphedema at age 11 here in the Houston area. And our next speaker, Dr. Carolyn Fife, was part of that team. And actually, so was the other speaker, Missy Baylor, our lymphedema therapist, was part of that team as well. So I've known Dr. Fife for now, I guess, 21 years. So it's awesome to now collaborate with her and hear all the great content that she has in store for you guys. So without further ado, Dr. Carolyn Fife.
Hey, Cam, thank you so much. You were an adorable kid, and you forgot to mention that you are one of those heartthrob bachelors on television. So you just never know when you're meeting people who they're going to turn out to be. You were an overcomer as a kid. You were an inspiration. So it's fun to see the wonderful career and the way that you use something that could have been a catastrophe to help other people. That's a really fabulous life lesson. So I as always, I have a problem with being a little over optimistic on how much information I can cover. Can you see my my slides here?
Yep, we can see it.
Okay, good. So I am going to talk for 30 minutes, but of course I have twice that many slides. And I'm also, you know, they say you should never start a talk with an apology, but I am afraid that people are going to be disappointed that I'm not going to give as much information about treatment. But Missy and I have done lymphedema and wound care courses. And the way we usually start our courses is just by beginning to get everybody on the same page about definitions and what some of these physical findings look like. And one of the things that makes lymphedema such a challenge is that there are so many strange and fascinating changes that the body can undergo. And we actually have a little bit of a struggle to create a common vocabulary so we can talk about them. So I thought today I would go through some pictures and vocabulary because it provides the framework to talk about wound healing. So our goal is going to be to identify the different types of skin breakdown and physical findings that commonly affect lymphedema patients and become familiar with terms. And I have already emailed Cam and Sophie a PDF of this talk. So don't worry about trying to make notes. You'll have all these pictures. But if there's a big theme for this little talk I'm going to give, it's what do I call that? But I posted on my blog a sort of a visual a slide presentation of different findings with the names. And the background for this project was really interesting. It's a taxonomy for skin disorders in lymphedema patients, because as part of the lymphedema framework project, Wade Farrow and I were tasked with reviewing all the literature on wound dressings for patients with lymphedema. And we couldn't pull the articles because no one agreed on what to call some of these physical findings. So we couldn't discuss how to treat them if we couldn't agree what to call something in a medical paper. So part of our framework project ended up being trying to get a common taxonomy for these findings so that then we could talk about how to treat them. So what I, as part of the apology, we're not supposed to make in a talk. If this is too basic or you're already familiar with these terms, then bear with me. But one of the terms that we see and one of the findings that's very common in lymphedema patients is called lymphedema rubra. It's the red leg. And the reason that's worth bringing up is because so often this is misdiagnosed as cellulitis. And the important thing is that this area of redness doesn't feel hot to the touch with the back of your hand. You have to take your gloves off, clean your hands, put the back of your hand on the leg, and then wash your hands again. You really can't discern this through gloves. But this is because those blood vessels in the skin stay vasodilated. Oftentimes people may have had an episode of lymphedema, of cellulitis, and then for some reason in the lymphodematous extremity, those blood vessels stay dilated, but for some reason they're not really hot. So this is not something that has to be treated with antibiotics because that gets confused often. And another thing that you see in lymphedema patients that's not exactly a wound, but is a skin finding that causes people a lot of distress is neurodermatitis, which is also called lichen simplex chronicus. And sometimes people refer to it as the itch that scratches. You can find that patients can make sores because they scratch so much, but it's part of the itch scratch cycle that causes the affected skin to be very leathery. So this person who has lymphedema doesn't actually have an open wound that's draining, but they can't stop scratching their leg. And that usually requires help with the dermatologist to be able to get that under control. Now, this is a wound in a patient who has a venous insufficiency with secondary lymphedema. And I tried to sort of start at the surface of the skin and then move in terms of abnormalities. These are plaques, hyperkeratotic plaques. Keratin is that top layer of skin. And this is a hypertrophy of just that layer of keratin. And if you ask me why some patients have papillomas, or why some patients have hyperkeratosis, or why some patients end up with massive localized lymphedema, I don't have an answer for it. Somebody smarter than me may know why certain conditions present in certain ways, but just to make sure we have a vocabulary, when you see these areas that look, and you can flick them off, they stick pretty hard, but they are just the top layer of the skin. And usually when you take those pieces off, there isn't a wound underneath them. And that's a little different than the hypertrophy that you get of actual tissue. These are papules. They usually, we refer to them as papules if they're less than 1 centimeter round. And they may have very distinct borders. They may be indistinct. They can be in a lot of different colors and sizes. They tend to be pinkish in lymphedema patients. But here you can see some that are so tiny that they look almost like moss. And sometimes people would call this mossy foot, although there is a very specific condition called mossy foot that's caused by a specific problem. But these are fascinating because these papules are grouped together in a way that sometimes they're referred to as frog spawn or frog's eggs. It's not a very common finding, but the lady on the left has a particular place in my heart because she had been told that she had a sexually transmitted disease. And she was a very modest, conservative person. And it was very embarrassing and heartbreaking to her that the doctors who were evaluating her didn't understand that these were a manifestation of her pretty obvious lymphedema. And she needed a lot of reassurance because of the embarrassment she felt from that misdiagnosis. So it just continues to remind us that, you know, these are, our patients have so much suffering associated with the visual changes of their disease. And part of our job, even when we can't fix it, is to at least help them understand so that they understand what part is related to the inflammation associated with lymphedema. So we talked about papules. Plaques are sort of solid elevations, and they're usually bigger than a centimeter. They're usually bigger than ½ an inch. The word plaque is a French word that means plate. So you get the idea that these are confluent areas. And I can't explain why some patients have plaques and some have papules. If somebody, there's some very smart people, I see their names on the call. So maybe at the question and answer, if somebody knows the answer to that, they can chime in. And you sometimes see this word phlebolymphedema. I don't know how useful that term is, except that you see it a lot. And it usually refers to lymphedema in patients who their primary problem is venous insufficiency that's led to lymphedema, as opposed to congenital or primary lymphedema. And the lymphatic system just becomes overwhelmed from the excess fluid of the incompetent venous system. And this is a patient who has known venous insufficiency, and you can see they've got those nodular fibrotic changes in the skin. And the other term that you should be familiar with is Lipodermatosclerosis. And you'll notice that a lot of these terms really are linked to venous insufficiency, because so often the wounds that we see in patients who have lymphedema are really venous in nature, and the lymphedema is a secondary but often overriding problem. And lipodermatosclerosis is one of those medical terms that's a conjunction of several others. Lipo means fat, and derm is skin, and sclerosis is hardening. And it's an inflammatory skin condition that is associated with venous insufficiency. The venous hypertension activates their white cells. They leak out into the tissues. The white cells become activated and they start releasing all of these signals that tell the body to produce scar tissue and inflammation. You know, your body only has certain ways that it responds to stimulus, and sometimes those are not helpful. And so it's, in a way, it's a form of paniculitis, or hardening or inflammation of the fat, the subcutaneous fat. And what happens is that after having been swollen for a long time, the ankles, area around the ankles gets scarred and shrinks down. So that leads to a leg deformity that we, in Britain, they call it a champagne leg. In the US, we call it a bowling pin deformity. I don't know what that says about our national cultures, but it certainly makes them challenging to fit with garments. But it tends to force some of the edema up above the scarring, and it can be challenging to bandage them as a result. And this is a patient Missy and I took care of. It's a sad condition that's considered rare, but I think many of the things that the book says are rare, we see commonly if your practice is primarily focused on lymphedema. It's called Elephantiasis, Nostraous, Varicosa. And that really means the kind of elephantiasis that isn't from our region, or is of our region. So it's non-filarial elephantiasis. And these patients get warty-like lesions and a lot of fibrosis of the affected area. And this is actually a before and after. We used a variety of dressings to try to remove some of these really thick hypertrophied areas. And this is what it looked like underneath. So you see that even when you get rid of some of this excess skin and keratin, the patients still have abnormalities of the skin underneath it. Sometimes they weep and sometimes they don't. And massive localized lymphedema are when the patient begins to get these very large deforming enlargements that can be almost anywhere on the body. Missy became a fabulous expert at figuring out how to bandage these. I know some of you have also dealt with this. They are probably the toughest things we see. Sometimes they can be removed surgically, but that's difficult. They tend to be in patients who are morbidly obese. And Missy and I learned the hard way that you should not try to have these removed surgically unless the patient is in a weight loss program or has had bariatric surgery first, because they will come back. So now I'm going to talk about the skin disorders that are associated with the conditions that cause lymphedema. The take-home point for the next few minutes is that all wounds are a symptom. And there's no evil wound fairy. This is what I tell my patients. There's no evil wound fairy that goes around at night and gives you a wound. Your wound is a symptom of the underlying disease, some underlying disease process. So we have to make sure we understand what that disease process is. And we won't get the wound to heal unless we treat the cause of it, whether it's venous insufficiency, whether it's trauma, whether it's cancer or previous radiation. Even non-healing surgical wounds happen because of a reason. And by the way, the most common reason for a non-healing surgical wound is some sort of nutrient deficiency. So I know many of you have seen metastatic lesions, cancerous lesions. The most important thing to know about these is that you cannot heal them. Wounds that are caused by cancer can't be healed unless you can eradicate the cancer. Now, we have had patients that get radiation therapy. Usually by this time they have metastatic disease, so the patients have an unsurvivable cancer. But if the cancer can be eradicated in this local area, you probably can get the wound to heal. But cancerous lesions don't heal, so setting expectations in patients is very important. And I remember so well when I was a second-year medical student, a professor that I loved so much asked the class what the primary role of a physician was. And one eager person raised their hand and said, "It's to cure disease." And he said, "No, it's to alleviate suffering. So the other thing to realize about what we do is that healing is not always the objective, and it may not even be possible. Our goal is to make people comfortable, to try to help them handle the very unpleasant life, quality of life issues that happen because of wounds. If we can heal them, that's a bonus, that's wonderful. But making their suffering easier is probably the most important thing. These are situations that we're going to use palliative measures. You can take Flagyl tablets and crush them and sprinkle them into these wounds to overcome the odor. I don't know if Missy's going to talk about some of our other tricks, but we've even put odor eaters in bras and garments that are near the body. These do tend to ooze because the blood vessels don't have normal controls, and you can use the powder you can get at the CVS without a prescription, Quick Clot, to try to help with the oozing. And there are lots of tricks of the trade, some good materials that have been written about this, but as I mentioned, setting expectations is important. And usually what we do is ask the patient, what's the biggest problem that you have? Is it the odor? Is it pain? Is it bleeding? And then we tackle the thing that distresses them the most. And this is an area of massive localized lymphedema on the arm. This is as we all get older, we get that hanging down stuff. This is really a profound enlargement that impacts this woman's ability to move. And because it rubs on things, she now has an ulcer that is a pressure ulcer. So this is a case of there's nothing inherently preventing her from healing. It's the repetitive trauma because of the awkwardness of this location that's the problem. And if we can't figure out a way to protect it, then we won't be able to get her healed. Venous insufficiency with venous stasis ulcers may be the most common type of wound that we see. And they're always associated with edema, although you would think that would be so obvious we wouldn't even have to say it. But I see a lot of sores on the ankle that are not associated with edema, and the patients are referred to me for venous stasis ulcers, and they don't have swelling. So the reason is that they've got skin cancer, or they have an arterial ulcer, or they have an inflammatory ulcer that's just been misdiagnosed. So just because it's on the ankle doesn't mean it has anything to do with the veins. But very commonly, almost always, you see that very dark staining of the skin that is hemosiderin. That's actually iron oxide being deposited in the skin because the red cells leak out of the veins, stick into the skin, and the red cells have iron in order to carry oxygen for the hemoglobin, and that iron is left behind in the skin. Now, the theory is that it's the white cells sticking in the skin and releasing their inflammatory mediators that causes the venous ulcer sores. But there are some people who think that the iron deposition itself may be one of the reasons that people get venous ulcers. And you will notice that I didn't put a picture in here of this. I should have thought of doing it. Sometimes their drainage is brown, and you think that that's because they're infected, but it's iron that comes right out of the skin in the drainage. And you'll also see that these folks have weeping. Sometimes they don't even have a wound. They just weep through the skin, which, as you know, can happen with lymphedema. And then you may also see changes that are caused by chronic scratching. And they often have the Lipodermatosclerosis I mentioned. Here are the excoriations from scratching. They often get colonization of the wounds, and then they get sometimes extraordinarily colored drainage. If it's neon green in color, we often think that's Pseudomonas, but Pseudomonas is not the only bacteria that can cause green drainage. And so often we have to have some tricks directed at that. And so one of the tricks that Missy and I do is mixing 4 tablespoons of vinegar to a quart of warm water and using soaks. They're basically dilute acetic acid soaks. That's a real pearl. If you have somebody who has a lot of green drainage, you can rinse it off then with water. And the other problem is if you have somebody who has a really smelly wound that seems to have heavy colonization, you can take 4 ounces of water and put 6 drops of Clorox in it and put that in a spray bottle and spray that on the skin, leave it for 5 minutes, and then wash it off. And that is, if you're familiar with the term Dakin's, that's what Dakin's solution is. You want to be able to recognize when an infection, colonization where the bacteria are living on the surface of the wound can prevent healing, but it's not necessarily an emergency, and patients don't necessarily need to take antibiotic tablets or antibiotic by IV. But once you get the redness, which I know all of you have seen, and to which lymphedema patients are prone, those patients usually, and if they have pain, usually they need systemic antibiotics. The other thing you want to make sure that you do is pay attention to fungal infections. This is a patient with Tinea pedis. Many times patients have a real problem finding appropriate footwear. And this is a patient on the right who was using cast shoes. And I just show a new shoe versus the shoe they had. Their shoes get colonized. They have a hard time finding footwear. And often part of the problem is they'll use some house slipper that's got carpeting on the inside and is completely full of fungus and bacteria. So just check between the 4th and the 5th toes to see if patients have a source of fungus. They also oftentimes have fungal toes that need to be handled. And they sometimes won't tell you that there's a problem. This is a patient, when you lift up his pannus, he's got a pretty bad yeast infection under his pannus. And they don't necessarily offer that that's a problem. So now I'm just going to spend these last 5 minutes just talking about the process of wound healing. And then maybe at a later time, we can talk more about how to treat wounds. But wound healing is really a 2-stage process. The first stage is like filling in a ditch. You have to get blood vessels to grow in the hole. And you would fill in a ditch with dirt before you would grow grass over it. So the second stage of wound healing, or the final stage, is really skin growing. So the first thing that has to happen is blood vessels have to fill a defect. And on the left is actually a picture of a rat. That's the underside of a rat. And that yellow area is the wound. And we're showing you the blood vessels that are growing towards that hole. And imagine the fur being on the backside of that picture. So when you're looking at the vessels in a healing wound that look like raspberries or like raw hamburger meat, those are loops of capillaries that are growing from below, filling in the defect. And that has to happen in order for skin to grow. I never get tired of watching wounds heal. And skin can only come from the edges or from hair follicles if the hair follicles are still alive, and you have an area that has hair, since not all parts of the body do, like the palms and the soles of the feet. But here you can see that skin is beginning to grow from the edges. And sometimes the skin, it thinks it can bisect a wound so that it can make a big wound into 2 little wounds. But wherever there's dead material or slough, that may block the movement of the skin. So part of what we do is try to manage those barriers. And this is an interesting picture because at the top, you can see that skin is beginning to grow from the north face of this wound. But the bottom, there's a ledge that curls under, and the skin can't grow over the wound because it can't deal with that ledge. And those are wounds we often take a scalpel and peel away that edge so the skin doesn't have a barrier. The other thing when you're evaluating wounds that you need to think about is how deep it is. When you see blisters that often happen as a result of rubbing, those are partial thickness wounds. And sometimes you see those when the skin just begins to peel off a little bit because of bandages rubbing or because there's been an infection or inflammation. But once you get past that sort of blister level, when you get to a wound that either has yellow slough or you see the little pink dots of blood vessels growing in, that's a full thickness wound. And if that helps you think through how to describe a wound, this is a full thickness wound that's a burn from a heating pad in a paralyzed patient who could not tell how hot the heating pad was. And I posted this on my blog for my patients. If you'll excuse the food reference, I call it Pizza University to help explain wound management to patients. That a good, healthy wound looks like pepperoni. That's what we want to see, just a pepperoni pizza. But if they have cheese topping, that's the slough in the wound. Part of our goal is to get rid of the cheese. And if it has anchovies, if it has a black eschar, that's usually full thickness, loss of tissue, all of that's going to have to be cleaned out before the wound can begin to heal. And what you're experts at is the rest of the wound assessment, because of all people, you know what excess drainage looks like. If it's clear, that's usually serous. Most of us are unfortunately familiar with seeing wound drainage that's green or smelly or purulent. What I tell the patients is that the pesto sauce is bad. We don't want any pesto pizza. And the other problem that many of our patients suffer from is that their wounds are draining so much, it keeps the skin around the wound too wet, like they've been soaking in a bathtub for too long, and it gets very white, and that's called maceration. So when you see that super white tissue, and it looks white no matter what your natural skin color is, that's drainage that's been allowed to stay against the skin, which means that we need to do a better job with our bandages. So that is a very quick run through what some findings, how to describe them so that we can collaborate. And when you call me, because Missy does that, she'll say, hey, I've got this problem. Well, I know what she means when she describes something, and that helps us work together better as a team. And then we can figure out what the best solution is going to be. So hopefully you can take back over the presentation so that Missy can do her part. And then Cam, you can tell me whether we're going to take questions now or wait till the end.
We'll wait till the end. So thanks again, Dr. Fife. Incredible content. Everyone, I will be distributing those PowerPoint slides that she just shared in the presentation after we do the recording. So expect those. And if you guys need me to make introductions offline to Dr. Fife, I'm happy to do that. So now, without further ado, it's my honor to introduce our next guest speaker. She is a certified lymphedema therapist and has many other acronyms next to her name. A good near and dear friend of mine and an amazing certified lymphedema therapist. Missy Baylor, take it away.
All right, give me just a minute. Let me share my screen. And are we good there?
Yep, we're good to go. Okay,
so I'm going to follow suit like Dr. Fife and make an apology because there may be some redundancy to what I'm going to say. But, you know, they say it takes you 7 times to hear something before you remember it. So maybe that won't be such a bad thing. All right, so let me see if I can get my screen to move here. Hang on just a sec, it's not forwarding. Oh, there we go. Let me go back. Okay, so just briefly, that's just my experience. Y'all can go back and look more at that in the rerun. And but just know that I've been doing this for about 22 years, so it's a little bit of time. Also, did you know that besides being Lymphedema Awareness Month, it is National Wound Healing Awareness Month? And just think about if, you know, when you go to Disney, they say that's where dreams come true. But what if we had a lymphedema land or a wound care world where physicians knew all about lymphedema and how to treat it and learned, you know, had more than 30 minutes of training in medical school? And what if insurance carriers could, you know, cover the garments at 100% and put no limits on therapy? Just how wonderful would our jobs be if that was the case? So why do we want to focus so much on skin and nail care and wounds? Because lymphedema is a protein-rich fluid, it's an ideal source for bacterial growth and pathogens. And the skin, if it becomes very dry or thick, it can increase the risk of cracks and fissures where these, you know, nasty things can, you know, get in, which they're actually usually there on the skin anyway, but if there's an opening, it gives them an opportunity. So we really want to focus on basic skin care, you know, keeping it clean. We always talk about meticulous skin care. And the manual lymph drainage really does help to reduce some of the skin changes that are happening along with this condition. So we hear this word a lot now. It's called microbiome. So the skin has its own microbiome. And this is why we really focus on skincare, because we have these, you know, fungi and bacteria and virus and things that are there normally. But like I said, if things change within the microbiome and there's too much of maybe too much moisture or not enough good nutrition, then you can have overgrowth, and that can lead to the inflammation, the infection, and prolong those healing processes with the wounds. So anytime you have chronic inflammation, that does increase your risk of infection. So there was a really good talk, Learn has it on their website. Dr. Perdrize, I'm not sure if I'm saying his name correctly, did a talk on the difference between cellulitis and inflammation. So I recommend if you have a chance to go and look at it, but he shows and talks about the signs of inflammation, the warmth, the redness, the increased swelling, pain. These tend to happen bilaterally in limbs, and a lot of times we see a patient come in the clinic and we're seeing these red legs and we're thinking, oh my God, there's an infection, there's cellulitis, but that is not necessarily the case. And so we have to kind of step back and look at what's really going on. If they have a cellulitis, typically that's going to be unilateral. You may just see it in one leg. But if that's happening, they definitely need to get immediate attention and get on some antibiotics. Compression is recommended. Now, if it is a cellulitis, we tend to wait until the symptoms have subsided or they've been on their antibiotics for 24 to 48 hours. The manual lymph drainage, that's a debatable topic as to when that can begin. But again, I think as long as the symptoms have subsided and they're on antibiotics, I don't see any reasons why you can't initiate, at least start that process. So the swelling, the lymphedema is a risk factor for the cellulitis. And then wounds become a complication of that process. So I'm going to focus on kind of an overview of what we need as therapists for our documentation. And again, like Dr. Fife said, we have to have that taxonomy. We need to know what we're looking at, how to describe it, so that we're all talking about the same thing. So we want to look at a wound and know, and describe those characteristics. What does it look like? What are the surrounding area? We want to be able to take pictures. We want to measure. We want to have something we can document on the changes. And as far as goals and being therapists, we always have to focus on, well, what is our goal with wound healing? We can have short-term goals, long-term goals, but ultimate goal would be to have wound closure, and also as it relates to their ADLs and how it's affecting their daily activities. So other requirements we may to look at, depending on your setting, could be nutritional status, pressure problems, repositioning. So we have those 4 stages of wound healing, and the inflammation stage is where we're most often going to see where those wounds are stuck. That's that step that they're just not getting past and they're not healing because of the inflammation that's going on. So normal signs of inflammation, redness, swelling, heat, and pain, but abnormal signs, if you have skin breakdown, bleeding, drainage, the area around is red, if they're running a fever, but also be aware that people that have chronic wounds, these signs may not be obvious in people who are immunosuppressed. So just a few pictures of a lady I saw that came in for initial eval, which that leg really does look like it has a cellulitis, and maybe it had a little bit of infection, but when you step back and look at both legs, you can see that there is a lot of inflammation in both legs. Over time and with treatment and with the right compression, you can see that color has greatly subsided. And you can also see she kind of overcompressed with her straps. So that inflammatory process is contributing to the chronic wounds and to the failure of healing. So we have different types of wounds that come in, and patients, when they're coming in, they may have a nice little gouge in their leg. This first picture is a lady that got hit by the car door in the back of her calf. So that's an acute wound. And once we did manual lymph drainage and did some compression, she healed it very quickly within a week. I mean, she was a very fast healer. But then we have someone else that comes in with a chronic wound that's been there for a while. And these are usually related to the venous arterial problems that that people are most often are going to have, especially in the wounds for legs. Dr. Fife kind of went over this already, that these are the wounds that we're typically going to see associated with lymphedema. We want to talk about too those descriptors that we need for the wounds. Is it superficial? Is it partial? Full thickness? What is the tissue like? What does the color look like? What kind of scales are we using for descriptions in our documentation? Superficial thickness is just a very, just the epidermis. It's going to be a little bright pink or red. It's going to heal fairly quickly. It may not even need any type of compression if there's no swelling. Partial thickness, that's more into the dermis, portion of the dermis. Again, it's a little bit more on the superficial side. You're not going to see bone or tendon or muscle. It heals by the epithelialization that Dr. Fife had mentioned, where the cells are trying to migrate across. These are some of the examples you may see partial thickness in blisters, second-degree burns, pressure ulcers. And then full thickness is where you're down to that third layer, and that's where you're seeing tendons and bone and things that really prefer not to see when they come in to see us. If you have a wound that is tunneling, that's an area underneath the skin where there could be a passageway from one area to another. This is a potential for an abscess formation, commonly seen in dehisced surgical wounds, neuropathic wounds, arterial wounds, and pressure ulcers. This is the undermining she mentioned earlier, where the tissue around the perimeter, the edges are pulled away. And then we want to look at the wound bed color. There's the pizza. Is it red? Is it yellow? Is it black? What percentage of the wound area is, or are these colors? What kind of exudate or drainage is coming out of this wound? What's the consistency? Is it clear? Is it more of a reddish tinge, the serosanguinous? Is it more bloody, which is sanguinous? Is it purulent, which is the pussy look? Is it brown? You have to think about the colors and what's happening here. What amount of drainage is there? There's a varying degree, and sometimes it's kind of hard to know how to describe how much is coming out until you've had a wound dressing on there and seeing how much is being absorbed into that dressing. Is there a smell? Is there no odor? Is it a bad odor, sweet odor, strong, pungent, fecal? You do want to make sure the odor is coming from the wound itself and not from the wound dressing, because there are certain wound dressings that can have a smell to them once they have been on. You want to look at the edge of the wound. Are the edges connected? Are they not attached? Is that epibole, that rolling there? Is it macerated? Is the skin dry? Is erotic? These are some of those descriptors also for the skin. And I didn't go through all the pictures because I felt like there may be some redundancy here, but these are terms that we want to use for skin that has some of these changes that are happening. The denuded, where it's missing some of the top layer there. Is it calloused? Is it hard? Is it red? Is it dry and scaly? Does it have a skin overgrowth? How much edema is there when you press in? How much pitting is there? Is the skin warm, cool? What does it feel like when you touch? And is there pain? Is there only pain when you're touching? Is it chronic or acute? What type of pain is it? You have a lot of pain descriptors for that, and most of our EMR records have all these pain descriptors to pick from too. If a patient is having a lot of pain with their wound and they're coming in to see you and you're doing wound dressings, you may want to recommend they do their medication before they come in so that it's not as uncomfortable for them. Other wound assessments, how long have they had the wound? Where is it located? The shape of the wound, the size. You want to measure, and that way you can document the changes that are happening along with your therapy of where this wound is, where it started, and where you're headed. So when we measure, we use a clock reference, and the 12 o'clock is if you were looking at the patient and the limb, and the 12 o'clock would be at the head. So 12 o'clock is the head and 6 o'clock is at the feet. Now, the only difference to that is if you're looking at a wound on the bottom of the foot now, and that changes. The 12 o'clock would be where the toes and 6 o'clock at the heel. But you want to measure at the widest from side to side. Helps if you have a wound measuring tool, and those are easily come by any vendor that does wound products. And we want to use the right dressings. So the appropriate dressing for the wound. We want to make sure we're maintaining that moist wound environment. I always think of it as a Goldilocks situation. You don't want it too wet, too dry. You want it just right to allow that migration of cells to come across that wound for it to heal. You want the dressing to be able to absorb, but not to retain so much that it macerates the skin. If we're wrapping over it, we do want it to be somewhat of a low profile so that it's not applying more pressure than what's needed. We want it to conform to the wound bed. We want to fill in the space. We don't want it to stick to the wound, obviously, because that is very painful during a wound dressing change. And we always need to be aware of any allergy potential. Some people have a reaction to silver dressings, so you may not have be able to use a silver dressing on them. We want to try to have something on them they can keep on in between visits that is, again, comfortable, is absorbing enough. And the other thing is we want it to be cost effective if, especially if their insurance is not covering any of these items. So what do we want to use? It depends on the site of the wound, the amount of drainage, where the wound is in the healing process, what the surrounding skin looks like. Is the patient or their caregiver able to change the wounds? And then cost and reimbursement sometimes is an issue as well. So this is our wound care mantra. If it's dry, make it moist. If it's wet, make it dry. If it's necrotic, debride it. If it's irritated, smooth it. So the ultimate function is to provide the right environment, enhance the wound healing. There are wound cleansers that are more effective in some cases than soap and water. Soap and water can sometimes be a little caustic to the skin, depending on the soap. So I prefer to use a commercial wound cleanser. The brand that I use is, don't know if I want to mention it, but it's a hypochlorous solution, and it is very comfortable for the patients when you're using it for cleaning wounds. So you have this acidic and alkaline balance that you need to be aware of. So we want to be able to remove the surface debris and the contaminants and to allow that wound to heal. So for debridement, there are different types of debridement, but we want to do that because if you have a wound that has a lot of dead skin hanging around, you've got another potential for infection and things to start growing, and that's not helping with the wound healing. So we want to get those things removed. So this is a patient that I've actually just started seeing this week. He came in, the first picture, it was just the other day, he came in and I applied a Xeroform dressing because I have very basic wound supplies in my private treatment office. So I have just a handful of things that I used, but I used a Xeroform for the antimicrobial component, also for a little bit of the moisture component because he had a lot of dryness in that wound. And then that next picture is the second day when he came back, and I was able to remove some of that devitalized tissue. I don't get really aggressive with it. I just kind of let it come off on its own. But you can see already in just one day, there has been a change in that wound appearance. So the types of debridement, depending on your setting and your level of training, you may not be using some of these. Most of us can do a mechanical debridement with, a washcloth or a gauze. We can do a very limited amount in some cases. With the surgical, that's more the scalpel, the scissors, curettes, and depending on your practice and your license, you may or may not be doing these, but these are the different types of debridement. So our objective with the wound care, you want to prevent infection, want to keep it clean, you want to maintain that proper level of moisture, eliminate the dead spaces, control the odor, try to reduce the pain. And the dressings, of which there are a multitude, and I'm not going into types of dressings for this talk because 30 minutes is not nearly enough time, but we want to maintain that moist wound environment, absorb the fluid, low profile. Again, this is kind of redundant of what I've been saying earlier. So these are the things we want to keep in mind when we're choosing a wound dressing. So if you're not overwhelmed yet, let's move along. And these are some of the things that will help with wound healing and with our wrapping with lymphedema. Silver impregnated cloth, the fuzzy whale textiles, barrier creams, of course, moisturizers, compression, and intermittent compression therapy. The first picture is an Interdry AG. It's a textile with silver impregnated, and it's a strip of cloth that you apply over an area that is wet and macerated, but you have to leave a portion of it hanging out for the air to wick it out. I call it the mini pearl wrap because it reminds me of a little tag that Minnie Pearl has on her hat. So that is great with helping to reduce a lot of skin maceration from a lot of exudate. The second picture there is a product called Edema Wear, and that's the fuzzy whale textile. And it's a stretchy material that what it does is it applies uneven pressures on the tissue. This is really good for fibrosis to soften it. I'll use this underneath a wrap once or twice just to get things kind of loosened up and softened. It can be a little aggressive, so you don't want to use it on somebody who has thin skin or directly. I know there are therapists that may use it directly over a wound, but again, it may depend on the type of wound that you're using it over. If it's painful, I wouldn't use it, but definitely it's a great tool for reducing fibrosis. And then the moisture barrier is really good for protecting that peri-wound skin when there is a lot of exudate, and that's mostly a zinc product. So this is one of my case studies. A patient that I saw, a 70-year-old female. She had chronic venous stasis wounds for over 2 years. She had done elevation, exercise, compression. She says she was unable to tolerate compression. And I told her, well, you've never been wrapped by me, so there you go. She was able to tolerate it once she got into therapy. Her impairment was 65% on the lymphedema life impact scale, and she was unable to wear shoes, and that was one of her goals. She wanted to be able to wear shoes again. It's just one of the goals for a lot of our patients that come in with feet swelling. So I used several things with her. I used a Vosh soak, that's the hypochlorous solution, with a gauze roll. I soaked the gauze, wrapped it around her legs, and let it sit for a few minutes. And then I used another wrap, which is a silver wrap underneath the short stretch, which is also an absorbent type of product. Eventually got her volumes down and fitted her into a Sigvaris Comproflex Light with a hybrid liner. And you can see that she has her shoes on. So that whole process took about 4 weeks from where she started there to here. So that's really not that long. If you're using the right products, the right compression, these things usually can come along pretty quickly. So this is my second case study, 60-year-old female. She fell in the bathtub. She developed 2 wounds to her left leg, and it required a surgical debridement and a wound vac. So those were the pictures of the wounds. I didn't take those pictures because those were in the hospital. I got those from the wound care nurse to have a before and after. So you can see where she started with this. It was pretty nasty. So we want to, consider where they started and where they're going. But these pictures on the right are the wounds after the debridement. So you can see that nice red beefy granulation. That's what we want to see. they put her on a wound vac. She got referred to lymphedema therapy. So she created a little bit of a challenge, and I like challenges. So this was a full leg wrap bilaterally, but the wound with the wound vac, I had to wrap around. So I was able to clamp the hose, and in some cases I could take it off and on to place products on her leg, but I created a hole for the wound vac hose to be able to come out of the bandage. I used a black foam there to help fill in kind of a hole that was there to even out the compression underneath the compression bandaging. So where she ended up, eventually she reduced almost a little over 6 liters in that right leg and almost about 2 liters in the left leg. So again, this was a very short period of time. We ended up using a Circade reduction kit for her for the lower leg, the knee, and the thigh. She was able to get this off and on by herself. Eventually got her into some custom flat knits. We struggled with the capris, and eventually she opted for some thigh highs, which again, she was able to get them on. In the beginning, she did need help from her daughter, but she eventually was able to do all that on her own. So when we're doing wound care and when we're seeing patients with lymphedema who have wounds, it really helps to have a team to depend on. You may have to reach out and get referrals or consult or have them go to see some of these other specialists if they're having a problem that you just can't seem to get a handle on, or you're not sure what's really going on. So these are very common, referral. These are people who refer for lymphedema, but these are also our specialists that we can refer out to when we have a patient that needs to be seen for these other problems. So look at my time here. So some of my resources, and we'll shout out to Dr.